So it's 11 minutes past 6, and I think it's a good time to start. It's 3rd of February. So good evening and welcome to our 19th webinar in the series CamDocUK Talking with the Community. My name is Dr. Linda Bello. I'm the chairperson of CamDocUK, and I will also be your moderator today. I will be ably assisted in the background by Dr. Valentine, our educational lead, Dr. Anna Benet, who is our communications and social secretary, and our very brilliant and able member, Dr. Mafo Foma, who is there in the background today. So our topic today, as you can see on the flyer, is organ and tissue transplantation in the Afro-Caribbean community. So why is this topic important? So let me just start with a few statistics. And I've taken this from the 2019 survey that was published by the London Assembly Health Committee. And it looked into the attitudes towards organ donation within BAME community, so Black and minority ethnic groups. And of those surveyed, only 1% stated that they were registered as organ donors. 42% were unwilling to become donors. 29% were willing or already registered, and 28% were undecided. 51% of people unwilling to donate said that they believed that it conflicted with their religion. 19% said it was because they felt it conflicted with their culture. So why is this important? Well, you can see that we don't have enough people on these registers. And so a third of the patients that are waiting for a transplant are unfortunately from the minority ethnic background. And the majority of those are waiting for a kidney. Kidneys are matched by the blood group and the tissue type, and therefore there is a better chance of finding a suitable match if the donor is from the same ethnic group. So there is a significant need for more organ donors of Black and also Asian heritage to help with the growing number of patients from these backgrounds that are waiting for life-saving transplants. Our speakers are going to speak much about this, but the theme you're going to hear throughout the talks are that you can donate a kidney while you're alive. This is a living organ donation, but most donations come also from people who have died. But to be an organ donor when you've died, you have to confirm and your name and decision of this on the organ donor register, for which we can see that only 1% of our community have done that. So we have 4 wonderful speakers today who are going to be bringing their personal and professional experiences. And I'm confident that when you hear them speak, you will discover how organ donation saves lives. They will dispel the common myths about organ donation, and you will understand the donation process. And most importantly, they will be happy to answer all of your questions. So without further ado, let's begin with our first speaker, who is none other than Dr. Elvis Ngassa. Dr. Elvis Ngassa trained in Italy, France, and the UK as a general and transplant surgeon. He has experience in kidney, pancreas, liver, and pancreatic islet transplant. So he covers a whole range of transplant surgeries, and he has worked in 5 different transplant units in the UK. He's currently working at St. George's Hospital in London. I have to add, being a CamDocUK webinar, that he's also a very active CamDocUK member. Dr. Ngassa will be talking about transplant surgery and how safe it is. So Dr. Ngassa, over to you. Thank you.
Hello, good evening, good morning, good night, depending on where you are joining from. Thank you, Dr. Bello, for that kind introduction. Before I start sharing my screen, I would like to make a small precision regarding the topic of this webinar. It says organ and tissue transplant. Yeah, that's a very, very wide range of different specialties. Yeah, you've got different surgeons involved in different transplants, like, you've got cardiothoracic surgeons dealing with heart and lungs. You've got abdominal surgeons dealing with pancreas, liver, kidneys, and even then you can divide them between people doing just livers, the hepatobiliary surgeons, and renal surgeons like myself doing mostly kidneys. Some renal surgeons like myself also do pancreas. Yeah, so the topic is really vast, but and it cannot be covered in just one webinar, but that means if there's great interest, we will run further webinars on this topic. Okay, so that said, today I will be talking about the safety of the kidney transplant surgery. So I'll begin with a small introduction. Just to confirm, is my screen sharing okay?
Yes, we can see your screen.
Okay, fine. So just to begin with a brief introduction, what is a kidney transplant? It's an operation which, in a nutshell, involves putting a kidney retrieved from a donor, in a healthy donor, into a recipient. And this is the treatment of end-stage renal disease. End-stage renal disease means the kidney has failed irreversibly, and the only other option apart from transplant when we get to this stage is dialysis. As you can see from the pictures, this is an example of a dialysis machine, hemodialysis machine, because we've got two types of dialysis, hemodialysis and peritoneal dialysis. So this other one is a peritoneal dialysis machine. And these are surgeons doing their job. So what are the types of kidney donors? We've got living donors. I won't give too much details on that because Dela will be touching that in the last talk of the evening. So living donors basically is from a person who is alive donating one of the kidneys. And we also got deceased donors, meaning that people who've died and they opted to donate the kidneys. So the deceased donors got two types: the heart-beating ones, meaning that they've got brain stem death, and the non-heart-beating one, meaning that they've got they died from a cardiac event, like cardiac arrest. So you can see from this picture that going back to donation, before coming back to kidney transplant, one person can donate to 8 different recipients from an organ perspective. 2 kidneys, meaning, with kidneys, 1 per patient. Lungs, the same, 1 per recipient. Then you've got bowel, you've got pancreas, you've got liver, you've got the heart. So
recording in progress.
So live donor transplant, what is it all about? It's when a healthy adult donates one of their kidneys to a recipient. Now the question is, what will then happen to me? So the answer is simple. You can have a normal lifestyle after donating one of your kidneys. No repercussions in your lifestyles. No repercussion from a job perspective. Who can donate? Who can be a live donor? So the answer is simple. All of you here watching this webinar, Maybe you can identify yourself here from the pictures. Maybe you can see yourself. So provided that you are medically and psychosocially fit, then you can be a donor. So what are the advantages of live kidney transplant? Best option is the best option for treating end-stage renal failure. Why best option? Because live donor kidneys usually start working almost immediately, if not immediately, and they tend to last for longer. Then, by opting for a live donor transplant, you avoid the waiting list. Currently, waiting list is averagely in the UK is averagely 3 years, and for Black people and people of Asian heritage, it's 3.5 years. So if you got a living donor, it can take like 6 months to work you and the donor, and your from work up to transplant, it takes like 6 months if everything goes straightforward. So you avoid waiting on the waiting list without knowing when you will ever get one or if you will ever get one. Yeah. So live donor kidneys are more successful than the deceased ones. You can see the happy brothers. How is the surgery performed? That's the question, the donor surgery. So got many techniques. Could be open surgery, keyhole surgery, hand-assisted keyhole surgery, and the novel robotic surgery technique. So the most used technique is the keyhole or the hand-assisted keyhole one. You can see the surgeons here. They just make small cuts in the patient and go in with this instrument and do the operation. And the operation usually lasts for 2 to 3 hours. And the donor will stay in hospital for 2 to 4 days. I've seen cases when they actually went home the day after. Some super fit people go home even the day after. And recovery time can be around a month. We usually tell them to wait for 1.5 months before going back to work. Most people who work in private will go back even after a month. So this is just a picture to show you the laparoscopic, which is keyhole. Laparoscopic is a medical term for keyhole surgery. So you can see small cuts and the surgeons go in with the instrument and do the job without making any big incisions. Then we've got the robotic technique, the novel robotic technique. It's quite a revolution because you've got this robotic instrument with the various arms inserted into the patient. And the difference is that the surgeon is completely cut off. This is the surgeon, not the DJ. The surgeon is completely cut off from the patient. He's got a console with some joysticks, which he moves, and that way he moves the arms by moving these things here, and that does the operation. So the surgeon can even be out of theater and still do the operation. Yeah. What are the risks of the donor surgery? Call it donor nephrectomy. So they're minimal, really minimal. We've got all the risks involved with surgery as a whole, like bleeding. I repeat, very minimal. Infections, like chest infection, wound infection, urinary tract infection. Very, very rarely. Hernia. And this one, which everybody, I think, should be curious about. What if I donate my kidney and I myself end up with, in the long term with, kidney failure? That's a very valid question. But what I can say is that before someone is selected as a donor, we run series of tests and make sure that the likelihood of ending up in end-stage renal failure is very, very low, if not, out of question. Yeah. So let's go now to kidney transplant operation itself. We've got the kidney out and gonna put it in the recipient. It's done under general anesthetic. And once the patient is put to sleep, that's under general anesthetic, we give them immunosuppressants. Immunosuppressants are medications which prevent rejection. Because if you put an organ or any foreign body into another human body, the tendency will be that of rejecting it. So we use immunosuppressants to suppress the immunity system, and by so doing, suppress rejection, prevent rejection. Yes, you asked me what Francis Ngannou is doing here. Well, Francis Ngannou has got a very good abdomen, the type of abdomen surgeons like, because you can operate on it very nicely. Well, so Francis Ngannou, I'll use him to show you how we do the procedure. Incision is made just above the groin on the right or on the left. Usually a curved incision, but it can also be an oblique incision. So the surgeon makes that incision in this space above the groin, create some space where he can implant the kidney. So you all ask me, why this space? Yes, this space, I will tell you why we use this space. But before doing that, let's go and do anatomy and physiology. Wow, anatomy and physiology, is this a medical lecture? No, simplified, extremely simplified anatomy and physiology of the kidney. So this is the kidney, this is how the kidney looks like. I just want to draw your attention to three structures: the artery, which is called the renal artery, which brings blood into the kidney; the vein, which is called the renal vein, which takes blood away from the kidney; and the ureter, which takes urine out of the kidney. So how does the kidney work? Blood goes to the kidney via the artery. The kidney filters the blood and removes waste products from it. These waste products are eliminated in urine via the ureter, and then the cleaned blood returns to circulation via the renal vein. That's all you need to know, and that's the end of anatomy and physiology. And now you can understand how this procedure is performed with that background knowledge. So, transplant procedure is done in that space above the groin because we've got the structures we need to attach the transplant kidney to. So transplant basically means joining those three structures I told you about earlier on to the recipient structures. So you join this renal artery to the recipient's artery, you join the renal vein to the recipient's vein, and then that ureter goes to the bladder. So all the structures are around that space, and that's why we use that space to implant the kidney. So that's all we do to do a kidney transplant. Yes, that question is inevitable. Yes, before we go to this question, most people will be asking what happens to my own kidneys when I get a kidney transplant. Now, generally, we don't go anywhere near your own kidneys. We leave them where they are, except they've got some issues, they've got some disease, they've got some reason we are worried that they might be detrimental to the transplant. Otherwise, we don't go anywhere near your native kidneys. So how successful are kidney transplants? So from the British Transplant Society statistics, we know that 9 out of 10 kidneys will still be working a year after transplant. And we know that 19 out of 20 patients who received a transplant will still be alive 1 year after the operation. Then, living donor transplants usually last for 20 to 25 years on average, while the deceased donor ones, 15 to 20 years. You can see the sisters are happy. What are the benefits of having a transplant? Well, people who have a transplant tend to live longer compared to other people with end-stage renal failure who continue to dialyze. The quality of life is better. You gain back your life. All the symptoms related to end-stage renal failure will disappear. You can go back to work. You can travel whenever you want. You just need to remember to take your medications. You've got few or no restrictions when it comes to food and drinks. Well, we always tell people to be careful with alcohol, which is like in the general population. And last but not the least, improve sex life and increase fertility. You can see brother very happy. He didn't wait for long after transplant to impregnate his wife. So what are the risks of kidney transplant? Like any surgery, there are some risks associated with transplant. Number one, transmission of diseases. Well, when I talk of transmission of diseases, we think only about infections. Yeah, but even cancer can be transmitted via kidney transplant or transplant as a whole. So the screening of the donor has to be very thorough, and that's what we try to do all the time. Then you've got immunosuppression-related complications like skin cancer. We always tell our patients, use the sunscreen, because with immunosuppression, you run a higher risk of developing skin cancer. Blood cancer is another one. Immunosuppressants, unfortunately, can also lead to diabetes. But at least we can play with the doses and make it less aggressive. Then you've got surgical complications, of course. All those joints I showed you earlier can potentially cause problems. They can leak, they can get narrow, yeah. More, and at times we need to go back and have a look in theaters. At times the kidney might not work. Percentage is low, luckily, because donors are highly selected, but this can happen. Then rejection, no new story. But what I wanted to point out here is that rejection is a treatable condition. It doesn't mean the end of the kidney. It just means give more immunosuppression. Diagnose it early to begin with. If you diagnose it early, the higher the likelihood of possible treatment. Diagnose it early and give more immunosuppression that can reverse the rejection. Then you've got this other one, not very common, recurrence of the end-stage renal disease in the transplant kidney. Yeah, this can happen too. Yeah, I couldn't end this discussion without talking a bit about pediatric kidney transplants, but it's the same in terms of donor operation, recipient operation, very similar. What I would like to point out is just some facts and figures. In the UK, last year, 127 pediatric kidney transplants were done. 77 were from live donors. It's mostly parents donating to the children, and 50 from deceased donors. Survival is excellent, as you can see. 90 to 95% are still working after 10 years. The half-life is around 12 to 15 years. So In conclusion, kidney transplant is the best treatment for end-stage renal failure. And most people who have a kidney transplant do well. And if you put in a balance the risk and benefits, the benefits outweigh the risk. So I will end it there and stop sharing my screen. Happy to take your questions.
Thank you so much, Dr. Ngassa. That was really very enlightening. We have so many questions that have come up. Some of our panelists have been answering them on your behalf. But I'm going to just ask you one or two of them, and then we will have time to take some more questions at the end. One of the questions which you already addressed was whether organ transplants were possible in children, the survival and the risk. And I think your last slide answered that, and Dela did answer that for you. And you did touch on whether being a donor, that a donor doesn't shorten your life. If you're, I think if you can just talk about that again. But first question, Dr. Ngassa, what do you mean by psychosocially fit? How is this assessed?
Yes, so in the donation process, you've got surgeons, nephrologists, psychologists, and even, I think, lay representative, just to make sure everything is done in a transparent way. I think Dela will talk a little bit more on that. While the clinicians assess the fitness, the medical fitness of the patient, the psychologists will also see how psychologically fit the patient is, because the donor is, because some people you can donate out of madness. We want to avoid such things. You have to know what you're doing. Let me put it that way. Yeah. One shouldn't donate as a result of the mental, illness. They're donating because they don't know what they're doing, or they're donating because they're mad, or they're donating, without being able to give an informed consent. So that's what that means.
Okay, thank you. And just one more question before we go to our next speaker. So you were mentioning about different types of surgery for it, and they wanted to know, if you're using the keyhole procedure, how is the kidney going to come out of such a small hole?
That's a good question. So those small holes are made to dissect the kidney, isolate the kidney, get it ready, and then when you need to remove the kidney, you make a bigger incision, a bigger cut, just as big as the kidney, just enough for the kidney to come out through. Yes, it's true. You cannot remove them through those small incisions. So at the end of the operation, you make a bigger one and you remove it via that one. We usually go very low in the abdomen. For women who had cesarean sections in the past, we use that same incision just in order not to give another incision. Yeah. So yeah, you're absolutely right. You need another incision to be able to remove the kidney.
Perfect. And I think many questions coming in. You're going to have to probably look at the chat. Please, may I ask the attendees to put it in the question and answer box so that we're not missing anything. But Dr. Wele has just come up with a question there. I'm sorry I've gone out of order, but she's out of the order in which the question came in. But it says a lot of people are unwilling to be living donors because they believe that they may need their spare. Is it possible to suffer from end-stage renal disease, but only one kidney is affected, or are both kidneys always affected? And that will be your last question. If not, we won't get to the next speakers.
If I understood well, the person asking that question is worried about, doubting if you get end-stage renal failure just when both kidneys are involved, or can you just repeat the question?
Let me repeat the question.
Yes.
I think it might be two questions in one. So she's saying that some people might not want to give their kidneys because they feel that they might need it in the future. And then in the same question, she's asking whether end-stage renal disease only usually affects both kidneys, or can one be spared?
They usually affect both kidneys, but one can be spared depending on the cause.
Okay.
Yes, depending on the cause. If it's a genetic cause or if it's a genetic cause, most probably both kidneys. If you've got things like glomerulonephritis, it's usually both kidneys. If you've got things like infections, at times, for some anatomical reason, just one kidney might be victim of recurrent urinary tract infections, and which can eventually lead to failure. So end-stage renal failure can affect both kidneys or just one. So I can see where the person asking that question is coming from. Now I've got only one kidney, and if something like that happens, I wouldn't stand any chance because that's the only kidney I have. Yeah, so that's why before considering someone to be a donor, we do lot and lot of assessment, number one. Then number two, after you've donated, your story with us doesn't finish there. We still see you. We still continue to reiterate that you need to lead a healthy lifestyle. I mean, simple things: exercise, avoid alcohol, proper hydration, and good nutrition. Nothing specific. If you can follow those simple rules, simple instructions, you reduce the chances of having issues with the kidney you've got left.
Okay, thank you so much, Dr. Ngassa. I mean, chronic kidney disease and the causes of renal failure is a whole webinar on itself, isn't it? But as I would please encourage you, Dr. Ngassa, to please look in the chat. Lots of questions there. If you in the question and answer, Dr. Ngassa will be able to at least start to type some of the answers, because don't think he'll be able to answer all of his questions. Lovely. So our next speaker is going to be on screen in a minute. There she is. Her name is Rosemary Atanga. She is a wonderful mom to her 3 boys, a humanitarian, a healthcare ambassador, an advocate for organ donation, and a champion for better health for kidney patients. Her background is in agroeconomics, and she also holds an MBA in marketing. She's not only a mother to her children, but many other vulnerable children on dialysis. And her passion for healthcare started after donating one of her kidneys almost 25 years ago to save a life. As the founder of Atanga Kidney Foundation, she has brought hope to kidney patients throughout the nation of Cameroon, and has equally organized many mission trips to assist with procedures like fistula surgery, thereby saving patients millions of CFA. Her greatest passion is serving her community and bringing hope to the hopeless. So Rosemary will be talking to us today about how donors have a good quality of life and how her foundation has encouraged donation. So Rosemary, and of course, all my lesson sisters will kill me if I don't say that Rosemary is also a lesson and the vice president of the Lord's Ex students. All right, then. Thank you. Over to you, Rosemary.
Hello, thank you so much, Dr. Bello. Thank you for having me. I know Dr. Ngassa has already given all the statistics, and I didn't want to go into that because I don't want to be asked questions on medical stuff that I have no real knowledge on. So I'm just going to share my experience and how this is also helping others make the decision to be an organ donor. Like you rightly said, mine started when I had my child. He was just 3 months old, and then my husband at that time was diagnosed with kidney failure. And it really took me by surprise because I'd never really understood anything about kidney failure or kidney disease for that matter. So I had to do the research and at 5 months, you know, of course, he started dialysis, but he could not be put on the transplant list. So we were literally paying out of pocket for the dialysis. He couldn't be put on the transplant list because we had just moved to the US, and the purpose was for me to just have a baby and then go back to Cameroon, where we resided at that time. So we really had to make quick decisions. He couldn't travel back because he was critically sick. So I had to do the research, and it's not easy, especially when you find yourself in that situation, for you to ask someone, can you give me your kidney? It's not something that anyone will feel comfortable asking. So I had to be the one to make that move. And so I contacted the hospital at that time, which was the University of Maryland Transplant Center. And even without his knowledge. And I told them that I was interested in becoming an organ donor, and I just wanted to get more information on what that entailed. And I got a whole lot of literature. And of course, when my child turned 5 months, I had to win him, and we went through the transplant. And like doctor said, it's a very, very, doctors don't just harvest your kidney for the fun of it. You go through a lot of question and answers. They ask you again whether you're sure about what you want to do. They go through your family history. Has anyone ever died from kidney failure? Do you have a history of diabetes, high blood pressure, and all of those things? So, and of course, I was in my late 20s, so I was pretty healthy. And when they also brought him in for testing, we did everything. I think we waited, the waiting period was like 2 weeks, and we were eventually confirmed a perfect match. So it's the exact day of the surgery was September 16, 1998. And it went very smoothly. Within 2-3 days, I was out of the hospital, but I had to go back because I had some bloating issues, and that was quickly resolved. And then I went back. And it's funny because the only thing I really asked during the only question I had for the doctor was that I love red wine, very good red wine. And I asked, will this impact my lifestyle? Will I be able to take my red wine every once in a while? And he said, nothing changes. Whatever you're doing to stay healthy, you should still continue doing that. And so I've just been doing that. But it's so interesting because when and that will answer a lot of questions that doctor has already talked about. When I did this surgery, because I did not really inform my immediate family, that is, my siblings did not know, my dad did not know. So people heard it most of the time through rumors. So people ask me, I heard this thing about this Cameroonian lady. I'd been in so many places where people were talking about it. And again, in the 90s, it was really odd. So I'll hear people talking about it. And for so many, I mean, the stories were so gruesome that that was when I developed fear, because I started thinking that something was wrong with me. And people would say it in a very, very scary way. They cannot imagine that this lady donated her kidney to somebody. How can somebody be living on one kidney? So I became an introvert overnight. I couldn't tell anybody. I thought something was really wrong with me. And when my brothers heard, I had friends who were even in the medical field, nurses, they cried. How could you do something like that? Why didn't you even ask somebody? And they started calling their spouses and telling them, hey, should something like that happen to you, don't count on me. Go through the normal process of waiting. So it was a whole lot of emotions from family, from friends. And I went home. I had people telling me, don't even tell people, because this is not something that is consistent with our tradition. And when people hear that you are a donor, they might be afraid that you have some witchcraft powers or so. It was really, these are real stories. That's why I didn't really have to do any presentation. These were things that I went through. I was really, really stigmatized to the point where I could never share my story. But it's interesting. I once attended a conference, a women's conference with Dr. Joyce Ashutangtang, and she was sharing her story and her personal story about divorce and all of that. And it really inspired me, because she said, your story might be a blessing to someone else. And when people live as a result of stories told. And so if you cannot tell your story, you're keeping a lot from a whole lot of people who could benefit from that story. And at that point, I thought it was a very great opportunity, and I started sharing that story on Facebook, and it was so amazing. The first time I put the story out there, and people were, okay, so you were the one who did this, and so it was very, very inspiring when the support that I got when I shared the story. And of course, around 2009, I heard that the dialysis center, there was a dialysis center in Bamenda, and I decided to just go visit the center to see what they're doing there. At that time, I think it was Dr. Awasum, who was the director of that center. I went there and I was really, really moved when I saw this 17-year-old child who was a student and battling kidney disease. That was like a light bulb moment, because I never knew that little kids like that. I just thought it was an illness for, older people. I didn't really think somebody that young will have. And before I left that hospital, I was so in tears. Whatever I had in my bag that day, I emptied it and left it for those kids to be taken care of. And so I kept doing that over and over. And of course, I was a volunteer at that time for the Pacha Foundation. So I used to travel a lot on mission trips with them. And around 2015, I decided to launch the foundation because I saw the need that first, it was not something that was very, people were not really aware of it. And the stories I heard going, especially in Cameroon, about some of those kids, especially the girls, most of them, and I'm sure people will be shocked to hear that when girls especially were diagnosed with kidney failure, and they had to ask all these questions from the doctors, and then their parents realized that they would not be able to have children. They would just take them to the village and wait for them to die, because they'll be like, no, I don't want to have to be paying all this money, of course, which I don't have. So that really touched me. And I said, you know what? I told the dialysis centers, I said, whenever you run into patients like that, make sure you call me. And I'm glad to see Iya online too. We've been begging online back to back. She's begging on her own side, I'm begging on my own side, rallying to support kidney patients in Cameroon. So it's been a very, very worthy cause. I don't think I've been humbled, even being an organ donor, to be able to impact so many lives. And from Bamenda, I also extended my activities to Boya, to Yaoundé, to Douala, and I've had to host a program on CRTV. So it just became like an addiction. And it was not only about helping these patients, but most of all, creating awareness about kidney disease. So we'll hold seminars with medical students in University of Bamenda. We did a lot of things. And so far, we've brought awareness to over 6 million people, especially when we had the first program where we brought kids on TV. I had calls from Cameroon. People were crying. They never really thought little kids were going through something like that. And in my community, I also do a lot of advocacy, because it still remains very, very stigmatized. But I think the community, and I think when Iya speaks, she will also confirm that the community is becoming more open, because when they see me, they realize that I don't really have a problem. So they keep asking, so what if, how does kidney failure affect, do you lose just one of your kidneys or both? And doctor has already answered that question. For the most part, depending on what the cause of your kidney disease is, most of both of your kidneys will fail at the same time. So I keep educating people on, the fact that you can live a healthy lifestyle, and just like you were when you had 2 kidneys. And I've been doing that for the past 25 years. Actually, this September will be the 26th year. And my donor is still, my recipient is still doing very, very well, even though he had a second transplant. But it's a very, very noble thing. And I think we still have a whole lot of work convincing, especially families who face similar things, because everybody is looking towards someone else but their family members. So most people are looking at having kidneys being donated from different sources, but they are not looking at their immediate families. And I always ask them, if your family member is dying, and yet you're waiting for a hero from another family. What does that make you? So you have to first you have to go through your own family members to see who is able to donate. And then of course, if there's nobody, then you can let your family member be on a transplant list so that, they can stay there for as long as they can have a kidney. So what else did I want to share? Yeah, so that has been basically what I've been doing for all these years, educating people on organ donation is still a whole lot of work. But guess what? We continue to have a lot of wonderful testimonies. I've had even Americans reaching out and going through the same process that I went through. I've had Africans, over about 4 families have had kidney transplants, which is just family, husband, wife, and, sister, brother. So it's been very, very encouraging. And as difficult as it is right now that we don't have many donors, I think people are changing their mindset. They are seeing so many donors and it's giving them hope. And I'm equally working with the nephrology, the head of nephrology in Cameroon, to do more advocacy, especially that they are now hoping to start doing transplants. And it's very interesting. One other thing that I wanted to share is that even the number of families who are actually taking some of their girls to the villages to wait for them to die has reduced drastically. We had this lady who also had kidney failure. She was in Bamenda, and miraculously, she got pregnant. I remembered when the nephrology in Bamenda called and said, your daughter Cecilia is pregnant. I called her. I said, how did this happen? She said, Mommy, I don't know. I said, so what are you going to do? She said, I'm going to keep it. I've not been seeing my period for the longest time. So if this happened, I'm just going to keep it. I called some doctors here to work with her, but everybody was scared because of how critical it was to take care of her. But we were able to rally for funds for the whole 9 months, and she gave birth to that baby, who is about 4 years old now, actually 5 years old, and she's still doing well. So we are doing a whole lot of work that I'm proud of, and I just have a slideshow to share. Just 1 second. This was even made by one of my friends when I had an event. And as I live each day, may I do my part to make a difference and touch one heart at a time, one kidney at a time. And it's my goal each day to bring smiles and laughter into a soul. And if you want to be an organ donor, this is exactly what you do. You indicate that on your ID. So here's my ID. So I'm a living organ donor and I'm still an organ donor. So should something happen to me, whatever is left of me should help those who are alive so that they can keep living. And I keep telling people, when you're an organ donor, you actually live multiple times, because the number of lives that you save, you're living in those lives. I had a family whose child was an organ donor and they did not know he was a medical student. And immediately they announced to the mother that, the guy had an accident and died on the spot. But of course, they had to harvest his kidney. So when I went to the home of this parent, her tears were different. She was crying for a totally different reason. Not only had she lost her child, but she said they were going to harvest her child's kidney because she had this thing on his ID. So she was crying and begging that if she takes this boy to the village, they are going to kill her if she doesn't have all So I asked her, how would they know that the boy's parts are all in his body? She said, no, the village people will go and find out and they'll think that she has sold the boy's body parts. It was real. This is an educated woman, by the way. So I talked to her over a period of time to make her feel at peace. And I told her how heroic her son was, even at that young age, to have thought about donating his organs. And she felt peace. And she has been advocating, even though not as much as I do, but she now understands exactly what it is. And I told her, you have a right to find out exactly the families that benefited from your son's organs so that you can connect with them and keep his spirit alive, because he's alive. He died physically, but he's alive in all the multiple people whose lives he saved. So here am I in doing the things I do when I go home, volunteering during a medical mission. I think this was in Kumba. I can't remember. I think this was also in Kumba. I just used the one, and here are some of the patients that we take care of. I think this was the dialysis center in Bamenda. Sometimes you're talking to patients, they just broke your heart with their tears and their stories, but we keep doing what we're doing over and over. Sometimes I'll sell stuff to support kidney patients. These are rosaries. Oh, this one is me and my school principal. Sometimes we go out there to work and we do what we got to do, climb on the bike and, you know, faces of some of the patients we work with. And I do this through the Atanga Kidney Foundation. And I believe that they are angels amongst us. And we are all angels, one way or the other. And I hope through my story, somebody feels inspired to know that there is no reason to be afraid to donate an organ. And when you have that fear and you have someone who is sick and you feel like you need to talk to someone about donating, you can call on me. CamDoc, I have a relationship with them spanning over so many years, and as well as the other medical association here in the US. So we continue to work to make our communities better. So whenever you think you need help with being an organ donor, my phone call is available. And that brings me to the end of my story. Thank you all very much.
Wow, wow, wow. Thank you so much, Rosemary. That was amazing. Your passion for everything you do and ongoing things that you're doing. You know, the chat is just buzzing with lots of, you know, amazing, fantastic, wonderful, clapping. It's just amazing. Please do look in the chat because I can't read everything that one has put in there. You've very inspiring story, and that's exactly what we wanted from you guys today. Thank you so much. You mentioned about the fact that you've given a kidney already and you've made sure that you are on the organ transplant list so that if anything happens, the rest of your organs shall be used. Amazing. In the chat box, we've also written about, you know, what people can do in the UK, because obviously you mentioned the US, in the UK about obviously registering to be on the organ donor, because only 1% of us, as per that study that I spoke about, are sort of organ donors, and you know, so it's really, really important. Many questions, many things in the chat. Please have a look. I'm going to just ask you one question, because it's just been there's been a lot coming in. I think one person said to you, Mrs. Rosemary, kudos to you for your generous heart and kidney. If I may ask, did you have any kids after you donated?
Yes, 2.
Amazing. And was there any difference in the pregnancies with you having one kidney?
Same nausea that I have all the time, same vomiting for 9 months, nothing changed.
Amazing. Again, and I mean, it's very clear that you're healthy. Do you have to have any regular checkups at the moment? Are you still having the
I
checkup?
do the same physical that I've been doing all the time, and I am in very great health. My BP normally runs from 120 to 67 or 70, so nothing except my usual high BMI, which everybody has, but we keep working on that all the time and just make sure that it's worse because I work from home, and I've been doing that for the past 4 years. So my BMI has increased a little bit, but I'm trying to improve my exercise routine.
Perfect. Rosemary, thank you again so much. We're going to come to you at the end when we're asking all the questions. As I said, please do look in the question and in the chat box. So many beautiful comments for you, and thank you once again. Lovely. So moving on to our next speaker, her name is Iya Bekondo-Granatella. She is a kidney health advocate and the founder of Iya Foundation and a kidney warrior. She was diagnosed with kidney disease at the age of 7 and subsequently lost her kidneys 10 years later. Through the support and charitable effort of her family, friends, and community, Iya was able to get life-saving renal transplant. And upon receipt of her transplant, Iya has made a commitment to helping low-income uninsured patients who suffer from end-stage renal disease, as well as educate, inform, and create public awareness about chronic kidney disease and organ donation. Iya will be giving her personal experience of being a kidney recipient and her lived experience of kidney disease. Over to you, Iya.
Thank you so much, Doctor. So I'm Iya. Thanks for having me on your platform. And I'm just going to narrate my story from diagnosis to where I'm at now. Like you rightly said, at 7 years old, I was diagnosed with nephrotic syndrome. And how that happened was that I developed certain symptoms like edema, which was swelling in my stomach, and puffy eyes. And my mom, who is now retired, was a registered nurse at the time. We were in Limbe, Cameroon. And she brought the Albu sticks, which is like a basic urinary test that we do even during our screenings. And she tested my urine and it tested positive for protein, which shouldn't have been so. That's where my journey started. We started going to the hospital in Limbe and we were directed to a nephrologist in Yaoundé. I think it was Dr. Nubisi at the time. So that was my journey for the next 10 years, periodically going to Yaoundé for checkup and managing my health with steroids. At the time, I was placed on prednisone and a very strict renal diet. I couldn't have salt and so many other things for a long time. However, the disease progressed, and approximately 10 years later, around 16, I started to develop very severe symptoms. I was cramping a lot. My blood pressure increased significantly. I lost a lot of weight, had no appetite. I had a metallic taste in my mouth. So my visits to Yaoundé, of course, became more frequent. At that time, Dr. UBC was no longer there. I started to see I saw Dr. Ashutang, who was the new nephrologist at the time, maybe 1 or 2 visits. And then my family decided that it was best for me to travel abroad to get to get better help. So when I came here, meanwhile, diagnosis in Cameroon, I'd been told that one of my kidneys were gone and one was functioning. So the hope traveling here was that maybe they would be able to remove one of the kidneys and then I would be fine. But I came, and even in the process of scheduling appointments, thankfully, my older sister is a nurse, Sharon, she's a registered nurse here. So I got into a crisis where I passed out and I had to be rushed to the emergency room. And I woke up with a catheter on my chest and I had been started dialysis. You know, they said my blood pressure was extremely high, my creatinine was extremely high, and I was really, really critical. So I started dialysis. I started dialysis, and then I was placed on peritoneal because I was really young at the time. I hadn't even turned 17, and they decided that peritoneal dialysis, which at the time was home dialysis, I could do it at home. They felt it was better for me to have a better quality of life, to maintain a better quality of life. So I did peritoneal for about 2 years until I had peritonitis, which is not uncommon with dialysis patients doing peritoneal dialysis, because doing dialysis peritoneal at home, you have to be very, very cautious. Even the air around you, you have to be all maxed up, you have to wash, so any little contaminant can get in there and you could get sick, So I had that peritonitis. Unfortunately, they couldn't I couldn't get back to doing peritoneal dialysis. They had to pull out that catheter. And then I had to go on hemodialysis, which at the time was mostly in center. So I had to go to the center, to the dialysis clinic 3 times a week. I was doing 4 hours on the chair for dialysis. So I had a permacath temporarily, and then I had a fistula that was planted in my arm. So you should see the needles. They have like 16 gauge needles that they inject to your arterial line and into your venal line. So blood leaves, goes through the machine, gets recycled through like a kidney filter, and then returns to your body. So I did that for another 2.5 years or so, about 3 years. So that was almost 5 years of dialysis before I was able to get my life-saving transplant. So my family had tested to become a donor. We've heard from Dr. and Sister Rosemary about organ donation. So we had been presented with that fact as a renal replacement therapy. And my mom had been seen to be the best fit. So even though my mom was ready and available, but I had to wait that 5 years because one, we didn't have the money. And for me to get anti-rejection medications, or as they call them, immunosuppressants for post-transplant, I didn't have insurance and I didn't have papers at the time, you know. So fortunately, I was able to attend college, and I was part of a group called AmeriCorps. And one semester, I couldn't make it to school because I was severely sick. I was sicker than usual, and I couldn't make it to school. And so AmeriCorps members reached out to me, and I told them about my situation. And so that's how they galvanized everybody, my church, my community, and they raised this money because the hospital, even though they had said they would do my transplant on a charity care basis, but they had to make sure that I could afford the immunosuppressants, which you need to help the kidney stay in you. Otherwise, your body is going to recognize this transplanted kidney as a foreign organ and try to reject it. So I needed that money. They needed $20,000. Thankfully, between my school, Middlesex County College, and First Presbyterian Church, in Metuchen, they came together and raised $40,000. We did a lot of events. We did a walkathon, we did a servathon, we did a golf tournament. So many events were done, and we were able to raise $40,000. And thankfully, my mom, without any hesitance at all, became my donor, and I got my life-saving kidney September 6, 2005. So that was like a night and day experience for me. While I was on dialysis, at the time, I was very sick, always sick. I was so thin. My complexion was very dull. My eyes were always so red. I wasn't myself at all. And having my transplant is like a 360 turnaround. You start to experience this kind of energy that you didn't even know you had. My skin came back to itself. I gained weight. I was healthy. I was doing so much better. I was able to travel again. I went back to school. I got my undergraduate. I got 2 graduate degrees, all because I was able to get a transplant and have this second lease on life. Granted, transplantation, I've mentioned immunosuppressants several times. You have to take a lot of medications. And right after transplant, you're on maybe 20, 30 pills a day for the first 3 months, because not only are you on the immunosuppressants, but you also have to take antibiotics. You have to take other supplements to help you adjust into your new lifestyle. So my kidney lasted 16 years, which in the US is the average lifetime of most kidneys. I had to go back on dialysis 2021. And the reason my kidney failed is I had a series of rejections. I had a rejection in the 10-year mark, and it was treated, like doctor had mentioned. If you have a rejection caught early, they can treat you. So I was treated with high doses of steroids, and I got back. They tweaked my medication, my immunosuppressants a little bit, and and I was able to continue life with my transplanted kidney. Unfortunately, I still had another rejection episode, and I think it was as a result of some UTIs that I had gotten. And those UTIs were, they realized that there was some reflux in my transplanted kidney. And what that means is that when I would urinate, some of my pee will not empty out completely, and some will reverse back into the kidney. So they realized that that could have been the cause. So I had to go back on dialysis. I'm currently back on dialysis. I always like to freak people out with this. I still have a catheter right here, a permacath that I use for my dialysis. Since 2021, I've been back on dialysis, and being on dialysis is nowhere near the same as having a transplant. When you're on dialysis, you're restricted a lot of things. Your diet is heavily restricted. You can't have too much salt. You can't have a lot of foods, potatoes, yams, plantains. You can't have too much of them because they're very high in potassium. And if your potassium is too high or too low, it could cause your heart to stop. So you could pretty much die. So those are some of the things that you struggle with. And if you have too much salt, then your body retains fluid, and then you're getting sicker. And even when you go on the dialysis machine, it's not pulling all the fluids that it's supposed to pull, because typically what the kidneys do, they help get rid of excess fluid. That's why you urinate through pee, and they help balance like your hormones. They help balance a lot of things in your body. So when you're on dialysis, you have to be very, very careful with your diet. And then like me, who is on hemodialysis, I can only drink up to 42 ounces of fluid, any fluid, including soups, ice creams, or water. That's accounted in the fluid. And that's very, very difficult, especially in the summertime when it's very hot, And sometimes just being attached to a machine, guys. There are times when my pressure would just drop drastically, and this is me passing out, and I'm seeing myself drifting away. And then the nurses, the machine beeps, and they have to add fluid. So it's very, very difficult. Your life is literally hanging on a machine, And then you have transplants, and I have to say successful transplants, because you've had incidents where people get a transplant and their body immediately rejects the kidney, or for whatever reason, or sometimes the disease reoccurs, the disease comes back, and the kidney doesn't work like it's supposed to, okay? But for me, and like doctor had said, a functioning kidney is way better than being on dialysis. Both are renal replacement therapies, but having a transplanted kidney, you have little to no restrictions on your diet. You're not stuck on a machine. I can barely travel now. I love to travel. I can barely travel because of the logistics it takes. I have to be on dialysis 3 times a week for 3.5 hours on the chair. And then you account for the time they're setting you up and the time they're taking you out. So it's hard to travel. They now have home hemodialysis, which accommodates for people to travel. People can now travel with their machines, with their devices, so they have their quality of life is not too restricted, okay? But at the same time, some of us like to keep our home, and so we would rather go into the clinic to get dialysis. But with transplant, you can travel. The only thing is taking your medications, right? You're taking your medications. If you don't take them, your body is going to reject your kidney. Okay, Amani, please go back there. Your body is going to reject your kidney. Okay, so I would encourage the community out there to not hesitate to become organ donors. If you're in the West, in UK or in the US, you just have to go to your motor vehicles and they will put it in your driver's license, or you just have to inform a family member your interest in becoming an organ donor. And one of the advantages of becoming an organ donor is that you're going to be screened. You're going to be screened so much that it's either you're very healthy, or if there's something wrong with you, they're going to find out and they're going to take care of you. So that's the best screening that you could ever have. Even if you don't want to donate your kidneys or an organ, just go and say you want to be a donor and see how much they'll screen you. And it's totally at no cost to you, okay? In the US, if you want to become an organ donor, you don't pay for anything out of pocket. And I am also like ambassador for the National Kidney Foundation and American Association of Kidney Patients. And we've been talking a lot with Congress, and we've been fighting a lot for donors' benefits. So you can be out of work, you would still get paid as a donor, you know, you would still get paid as a donor. I already mentioned there's no out-of-pocket cost, and you are well informed. Before you ever become a donor, you are well informed about the repercussions, about the benefits, everything. And you should know that even if you become a donor, at the last day, after even scheduling a transplant surgery, if you change your mind, they're not going to do it. I've heard people think that, oh, if you register to become a donor, if you're in a life, if you're in a critical, say you're in an accident, they will just harvest your kidneys. That's not true. That's not true. They'll take care of you until maybe you have brain dead, or and the doctors, the healthcare practitioners can decide that there is no hope for you before they would even try to harvest any of your organs, okay? So there is no risk to that. And most religions accept organ donations. So you can't say, oh, my religion doesn't. Most religions now accept organ donations. So I encourage the community to become organ donors, because Blacks are the most at risk of kidney failure, okay? Because we have the highest risk factors. The highest risk factors are diabetes and hypertension, and Blacks are the most at risk of those two ailments, okay? But yet we are the least donors. We need transplant the most, but we are the least donors. That's not right, okay? And gone are those days where we can be blaming stuff on witchcraft and all that. Oh, na person they do me, na person they poison me. No, the diagnosis now, people are being diagnosed. I've had patients in Cameroon who still think after being diagnosed, they can pray themselves out of the thing. I'm not to, you know, challenge any spirituality and stuff, but, you know, I encourage any patients that are watching now, if you're diagnosed, there's life after diagnosis, you know, educate yourself, learn about what you need to do so you can live a healthy life. Every time I go out, people, when I open my mouth and say I'm on dialysis, people are shocked, you know, but that's not because I'm special or anything. It's because I've learned what I need to do, So I encourage people to become donors. And also I want to say women are also at risk the most of kidney disease. However, men are the ones who get to dialysis the most or die from kidney failure the most. I guess because women take care of themselves better. Women, why women are at risk are because women they get pregnant. You know, women easily get urinary tract infections and other infections, so they easily get kidney disease. But again, men die from them the most. But you know, that's all I really have for you guys today. And thank you for having me. And I hope you go and become an organ donor. Yeah.
Wonderful, wonderful. Thank you so much, Iya, for that very moving testimony. I mean, as I will say the same thing I said about Rosemary. Please have a look in the chat. So much support for you. Everyone's telling you well done, courage. I mean, what I've noticed, obviously, we've only just met recently as we were preparing for this webinar, and what struck me when we first spoke is just how you look, how positive you are, your outlook and everything. And I wonder if you can just share a bit about how you've dealt with any issues. How do you keep going? How do you keep going? So I wonder if you could share some tips on, you know, because obviously you've been through a lot. Can you just share a bit of some tips about people that might be in your situation and how you keep hopeful? I mean, you work also full time. It looks as if you're also a mother. I can see someone in the background. How have you coped with everything?
A lot of it is mind over matter. I've dealt with this for a very long time, and I think waking up every day is a blessing. And when you're up, you just have to realize, what can I do to make my day better? I mentioned earlier about educating yourself about this disease, knowing what to do. You know, for me, managing my diet is key, because I get sick physically when I drink more than 42 ounces of water a day. I get sick when I eat too much plantains and potatoes, and my potassium is very high. I can tell the changes in my body. So that's another thing. You really have to listen to your body, take the time to understand your body, because even though kidney disease, it's across the line, but it's different for everybody. It's unique for everybody. When I went back on dialysis, I could no longer make urine. I don't make urine, but I know people who are on dialysis and continue to make urine. So they can drink without limitations, even on dialysis, because they are still able to urinate. Granted, their kidneys are not working. So you, as a patient, you have to understand your body. Ask those questions, no matter how dumb you think they are. Get a relationship with your healthcare providers, ask them those questions, and also having the support of loved ones. I cannot minimize the support of my family and my friends, okay? And for me, being outspoken about my health has helped me tremendously. I put myself as the poster child for kidney health. I'm always on social media. Find me, Iya Bekondo. I'm always sharing my story. So for me, when I share my story, they say a problem shared is half solved. Just talking with people sometimes relieves you of the pain. And sometimes you see that some other people have it worse than you have it. We have people who have no therapy for them to stay alive. So that's how I look at it. I have dialysis, and it helps me stay alive. So I'm grateful for dialysis. I'm grateful for transplantation. So I'm going to do whatever it takes for me to get to dialysis and get, my treatment, right? You have patients who are too tired, or they want to skip dialysis, and then they get sicker and sicker, So I've come across those patients, and you just have to counsel them. You have to understand this and be intentional about wanting to stay alive, about what you need to do. You're no different than that. There's somebody over there maybe suffering from hypertension or diabetes or lupus or HIV. There's a lot of things out there. Just do what you need to do to care for you. That's what I'm going to tell. And there's definitely life after diagnosis, so I'm available for anybody who would like to chat or talk about kidney health. So, yeah.
Thank you so much, Iya. I mean, we will get back to you with some of your questions when we've rounded up with our last speaker, who is certainly not last but not least. Dela has been waiting patiently, and I think, Dela, you'll really be able to sum up what everyone has said. Dr. Dela Idowu is the founder of Gift of Living Donation Gold, and it's an organization that works to raise awareness of living kidney donation in Black African Caribbean community. And she set up this charity after coming forward as a living donor for her brother who had kidney failure and needed a kidney transplant. Dr. Idowu will be talking about difficulties in getting donors from our community. So, Dela, Dr. Idowu, over to you.
Thank you so much. And I'm very conscious of the time, so I'm not going to keep anybody too long as the last speaker, but thank you. It's very interesting. One of the things I think every caller can say, that myth of Black people do not donate, I think today in this webinar, that's not true, because we've heard from Rosemary, we've heard how the last speaker, her mum donated. So when people say Black people don't donate, we can say, well, actually, yes, they do. My journey into the world of transplantation and organ donation really started with my brother. And one thing I have to say is that if it's not on your doorstep, if kidney disease or organ donation does not come to your doorstep, the truth of the matter is you really don't know about it, and there's a lot of people out there within our community, or even just generally don't know the difference between renal disease and kidney disease. So my journey into the world of transplantation started with my brother. He was diagnosed with kidney disease. He knew for about 9 months, and we've heard from a lot of the speakers, it is a very difficult conversation to have with your family, especially if you're from the Black Afro-Caribbean family. How do you then start to ask your loved ones, I need a kidney? So my brother knew for about 9 months. He did not say anything to me. It was only when we were planning to go home to Nigeria, which is my home country, and he said he can't come. And I'm looking at my brother thinking, well, why can't you come? That was when he said, sis, I've got kidney disease and I am going to need a transplant, or if I can get a living donor, that might help. I had never heard of living donation. So I'm like, well, what's living donation? And when he explained it to me, as his sister, for me, it was a no-brainer. I'm like, well, I knew we could live with 1 kidney. So I thought, well, if we could live with 1 kidney, and my brother needed 1 kidney, for me, it was a no-brainer to donate a kidney to my brother. And as we've heard from the previous personal stories, I did not want my brother to spend 3 or 4 years on dialysis, which is so common. I wanted him to go out and live his best life now. So for me, it made more sense. But it's common that people within the UK, if you're Black, you will spend on average 3 to 4 years on dialysis. And I did not want that for my brother. So I offered to be his living donor. And as we've heard from the last speaker, even if you don't know what's wrong with you, when you finish doing those tests, you will certainly have a clean bill of health. So I went up to Guy's Hospital. That was my local transplant center. We did the test. I was a complete, absolute 6 out of 6 tissue match for my brother. I think the 6 is the highest that you can have. We were the same blood group. But as we started to go on that journey and I kept on doing the urine test, the protein kept on showing in my urine. Didn't know what it meant. As far as I'm concerned, I was a 6 out of 6 tissue match. I was going to donate to my brother. But it was interesting when I was actually on that journey and I was saying to people, this is what I'm going to do. A lot of Black people, I would say at least 99% of the people I spoke to, these were churched people, unchurched people, people who were African or Caribbean, old, young. It was like, well, what's living donation? They had never heard about it. And I think they were confusing it with, as we said earlier, about people signing up to the organ donor register. And as we said earlier, only 1% of Black people are actually on the donor register. And they were like, no, well, I'm not going to do that. And I'm like, well, supposing you had your husband, your wife, your brother, your sister, your child, would you not want to give them one of your kidneys so they can have a better quality of life? And what I found out on my journey was that a lot of Black people within the UK would actually consider being a living donor, even though they had to go through surgery and have an operation that they didn't need, then signing up to the organ donor register. And again, for us in the UK, we know that's a lot to do with race, that's a lot to do with mistrust. So I was continuing on my journey. And as we said, you have to go for a very, very strict test. They don't just take out your kidneys. And unfortunately, it was when I was on that journey, they also realized, and there's another test that you have to do. And that question always comes up, well, supposing I need one of my kidneys. Well, because Black people are disposed to high blood pressure and kidney disease, there's a test called APOL1. And that APOL1 is a blood test. And it's normally given to people who are from the Black Afro-Caribbean community. And that's simply, as we rightly said, what we don't want is for us to then donate a kidney to our loved one. And then 5-10 years down the line, we then develop kidney disease ourselves. So that test for somebody from the Black Afro-Caribbean community is essential. It is so important. And that was the test that I had. And when I had that test, it showed that, albeit with my 2 kidneys, I was fine. I didn't even know I had an underlying problem. That's one of the beauties about having this test. Albeit with 2 kidneys, I was fine. But they did not want to take the risk of me donating to my brother if I had only one kidney. So unfortunately, they turned around and said to me, Dela, unfortunately, you cannot be a donor. I was absolutely gutted because I did not want my brother to spend 3 or 4 years on dialysis. He was very outgoing. We've heard how it's very restrictive. But I was really, really devastated. I think I was more devastated than my brother that I was told that I couldn't donate. But one of the things about myself was, okay, I can't donate. If I can't help my brother, can I help other people within my community? Can I help other Black patients know a little bit more about donation? And that was just really from my experience. So I went away devastated, but I wanted to turn something that was negative into something positive. So that's how I then started Gift of Living Donation. And we just simply raise awareness of living donation within the Black community. And it has been absolutely amazing. So I'm just going to quickly share my slides. I've just got a couple of slides I need to share. So we've been hearing about transplantation, why, I mean, Elvis has talked about it, but why is transplantation very important within the Black community? And we've heard a few stats, but I'm just going to bring it maybe closer to home, and especially London, which is one of the most diverse cities in the world. 50% of people who are on dialysis in the UK, in London, are from the Afro-Caribbean community. But we only make up 13% of the population. So you can see there's a huge disparity right there. And also Black people develop kidney failure 10 years earlier than white people. So you can see within our community, transplantation is just so important. But why is today so important? I mean, we've heard a lot of stats in the US and here, but let's just look at these figures. So these are the figures from NHSBT, and these were last year's figures. So we had 798 white kidney donors in the UK, and we had just 19 Black living donors in the UK. And when you think of the percentage of Black people who are in London or even in the UK, that is really, really bad. And for us as a community and for us as an organization, we could look at these figures and we can say, oh my God, that is really bad. And it is a problem. But as a community, we really have to be the solution to the problem. So a lot of the work that we have done within our community is being a solution. So what we've recently have done is we are working across London, and we're trying to work out with clinicians, well, how can we increase living donation within our community? And we as a community, as I said, have to be part of that solution. So we set up the Peer Buddy Scheme, which is a quality improvement program. And we work with people like Elvis and his team across London. So when clinicians, people like Elvis, are talking to their Black patients about living donation, it's a very, very difficult conversation to have. So more than often, what normally happens is that when Elvis and his team or some of the clinical nurses say to Black patients, is there anybody within your family that will consider living donation? 99 times out of 10, that answer is no. So what then happens is that they then start talking about dialysis. So it's almost as if dialysis then becomes the default treatment option for Black patients. And that's why we've got so many Black people on dialysis. I mean, the capacity of dialysis in the UK is almost coming to a crisis point. So one of the things we're saying to clinicians is that, look, community and culture are very important to our community. So why not include that when you're having your discussions? So what we've actually done as a Black charity is look at the renal pathway and say, look, if your renal pathway is trying to meet the needs of your Black and Asian patients, there is nothing in that pathway that has got a community intervention. So we designed an intervention whereby clinicians actually refer their Black patients to Gold. And then what we do, we then match our living donors up with patients. And basically all they're doing is like sharing their stories about living donation. And what we have seen, it has been an absolute success because they're talking to people from their community about living donation, people that understand that culture, people that understand some of the religious myths and challenges around living donation. I mean, I had a story very, very recently of a 19, and we've been hearing about children who was a 19-year-old patient. And I thought, he is too young to spend the rest of his life on dialysis. So one of the things we do is to call out patients that have been referred to the scheme. And I'm on the phone talking to this nice 18-year-old. And already he was like, yeah, how long is this call going to be? I can't stay too long. So I'm thinking, well, how am I going to get through to this 19-year-old about living donation? And he's Nigerian. And we started talking about soccer. We started talking about football. And this gentleman just became alive. This was somebody who 5 minutes ago wanted to get off the telephone. But then his dad was in the room and his dad was like, well, who are you talking to? And he's like, oh, I'm talking to this lady about living donation. Straight away, the dad came on the telephone and said, oh, I've been hearing about this living donation. What is it about? And I explained to him what the procedure was. I showed him my experience. This gentleman was so taken back that he was never really explained at the hospital really about living donation. He didn't really get it. But hearing it from somebody from his community has made a big, big difference. And that is what we're doing for patients. So he went up to his local living donor center, and he is now going through that process of being a living donor for his son. And that is so important about the community intervention. But it's not only for patients that have benefited from this, also clinicians, because we speak to a lot of your colleagues, Elvis, and a lot of them saying, do you know what? I feel a lot more confident now, knowing that this scheme is in place, knowing that I can direct my Black patients to the peer buddy scheme. I feel a lot more confident now in talking to my Black patients about living donation. And what we have seen is a reverse of mindset. So we're seeing a lot more Black patients now having those conversations with their loved ones about living donation. Because when you have those conversations, they turn into potential living donors, and potential living donors turn into transplants. So that for me, in a nutshell, is that as a community, it really is up to us to change the status quo. And we have the opportunity, really, especially now, especially I think working with a lot of the ICBs, with NHSBT, a lot of these stakeholders, because the truth of the matter is they cannot do this by themselves. I don't know whether Elvis would agree with me on that because he works for the NHS and maybe Linda, but you really need the intervention of the community because it helps change and delivers better healthcare services. So for me, today is like, okay, we've heard what we're going to do, but it's about the call to action. What I really don't want it to be, I don't want it to be, oh, it's a really good webinar. We've seen everything in the chats. This is really, really great. What are we going to do? Because it's in the doing that we bring about change. It took us about 3 years to design that peer buddy program to be able to present it to NHSBT. And yeah, we got a lot of stick, we got a lot of barriers, a lot of challenges. But unless you're in the shoes of Black people that are on dialysis 3 or 4 times a week for 3 or 4 hours, they can't travel home to their home country, we understand some of the challenges at the phone. So for us as an organization, we will keep on knocking on those doors. We will keep on changing policies. But it works in collaboration. And I think because we've been able to collaborate with a lot of the healthcare professionals, that's where the change has come. But it starts with us. If we're going to transform our healthcare services, if we're going to have better health outcomes for kidney patients, it's not the NHS, it's not Kidney Care UK, it's not Kidney Research UK, it is the Black community. So I'm hoping at the end of the webinar today, all of you will be messaging CamDocUK and saying, well, what can I do? How can I make a difference? What can I do to change things? Is it conversations? Can I invite people to my church to speak? A lot of us go to church. Can I invite Black living donors? Can I invite recipients? What can I do? And that really, for me, is a key word, that today, let it not just be a webinar that we hear about, but let's be proactive in making those changes, because that change can only come from our community. The more conversations patients are having with their families, the more potential donors might come forward, and the more living donors that we have, and the less people we would have on dialysis. So we're talking about, well, what can we do? You know, and one of the other projects that we've done, apart from the quality improvement, is that I set up the Black Living Donor Choir. Every single, apart from myself at the end, every single person that you see on this screen has donated a kidney to a loved one, husband, wife, daughter, father, son, even to a stranger. So music has been a powerful way for us to get the message out in our community. So we have a unique way of combining music, be it soul, reggae, Afrobeats, you name it, with their donor stories. And it has been such a fantastic way, because what you're saying to the community is that, look, these are people with one kidney, they're singing, they're happy. That is just a fantastic way of to say, well, actually, you can live a healthy life with one kidney. And these are the people who are going about. We've been up and down the country singing, sharing our stories. And we've had loads of family members who have said, well, actually, you can live a life with, you can live a healthy life with one kidney. And just looking at the donors and seeing them looking healthy, as we've heard from Rosemary, has been a game changer. As I said, it's up to us as a community to really make that difference and to get out there and to keep on talking about it. And to, you know, when people are saying that, well, Black people don't donate, you can now go away and say, well, actually, yes, we do. And we've got a fantastic website. It tells you all about the donor process, people's stories. We've got a toolkit. And because our project has been so successful, and we started with 3 transplant centers, and Elvis, we're coming to your transplant center this year. We now have been asked to run our project across London, and that's how successful it has been. And it's just that collaboration between healthcare professionals, clinicians, and the community that's making a huge impact. So thank you so much.
Wow, that's so wonderful, Dela. Thank you so much. Thank you for everything you do. Really, really inspiring. I mean, yes, you mentioned about the percentage of us that are here in the UK, in London, and the fact that, you know, even though we make up a small percentage, you know, 50%, you know, we're the ones on there, and we always have to remember that we're not in our home countries per se, and that it's always difficult for patients to relate to people that don't look like them. And I think what you guys have done is absolutely amazing. Why did we do this webinar? Because of passionate people like you, Rosemary, Iya, Dr. Ngassa, and this is what we want to do. Yes, we've done this lovely webinar. There's been lots of attendance, people listening. We're going to share this on our YouTube for people to share this. And really, the message that you're saying is a call to action. Yes, it's not that we don't donate, we're not donating enough. And the scale of, we need to donate more, because there's more of us, you know. Unfortunately, we're the ones at risk of high blood pressure, diabetes. Those are the things that affect our kidneys. And we've all shown, the donors here have shown that you can have a normal sort of healthy life with your one kidney. If you're worried about whether you're going to be safe with the one kidney, there is the special test that you were telling us about, that will just check to see whether what your risk is of developing it. So there's really no reason for us to do it. So really, really good. Dela, we have a question for you, which is, I mean, there's so many questions. I'm not sure if we're going to be able to go through them, but we're talking about donations. Can people donate that don't live in the UK? So for instance, if I have my relative in Cameroon that wants to come, unfortunately have a kidney problem, can they donate? And while you're talking about donations coming from countries from abroad, are you able to comment on there's a Nigerian senator case? I think, can you comment on that, about consent and altruism, if that's okay? Thank you.
Okay, yeah, absolutely, because most of us do have families in Africa, in the Caribbean. So yes, you can have a donor. You can have a donor from abroad. I must confess now that since the senator case, there's been a crackdown. It's not as easy and as straightforward as it used to be. So they're a lot more strict now in terms of medical tests. They're a lot more strict now in terms of proving relationships. So all of those things have, and I have to say, I sit on the kidney advisory board, and I have to say to them that we welcome those. We welcome those new policies that are put in place, because even as a community, to be fair, it was an embarrassment for us as a community, and even more for us as a Nigerian. So we don't want this to happen again. So we're saying that, yes, we want you to put these policies in place. However, you have to work with the community to be able to make sure that our voice is at that table when you're putting all these policies in place. So yes, it's still possible, because if they don't, what's going to happen is you're going to have more Black people here, unfortunately, on dialysis. So that it's still very important that if people have donors in their home country, it's possible. What we ask you to do is to make sure you do all your original tests, workup tests in your home country, and then you come here. But yes, it's still possible, just a lot harder now, a lot harder.
Excellent. Thank you. And I think there was a comment about the choir has more female female members than male members, so more female donors, or is it just that women like to sing?
No, that's a very good observation. Generally, we actually have a lot more women donors, and I think that's because who we are as women, which is a lot more nurturing. So that is the case. We have a lot more women donors. And I have to say, most of us on this call, we are Africans. I have to say, we actually have more Caribbean donors, living donors, than we do Africans. I think that's a lot to do with culture as well. A lot of us, we've heard about witchcraft. So there's a lot of cultural myths that prevent us as Africans donating as live donors in comparison to our Caribbean brothers and sisters. Yeah.
Okay, thank you. Dela, it's been really great hearing from you. I'm conscious of the time. I mean, all of you have been so amazing. I think I'd like to just go around the floor again and give the other panelists just some time to answer a few questions. I see Dr. Ngassa has been really answering lots of his own questions at the back there as well. There was someone that wanted to know about how the kidney was going to come out, which he did say that it would have to be an incision. And then someone else asked about if after a kidney transplant, does the recipient have to be on medication for the rest of his life? And he's answered saying the number of medication gets fewer with time. Another one, Elvis, where you were talking about your first ever transplant. Do you want to tell us a bit about it? How was that for you, and how is it now?
Yeah, it's very strong emotions. You will never forget it. So my first kidney transplant was in Cardiff, I think, yeah. And I was still a registrar, a trainee. And they took me completely unawares. Because that day I was working with the organ retrieval team. That's the people who go around from place to place in the country and, you know, take out kidneys from the donor. So that kidney was retrieved by our Cardiff team, and it was offered to us. So we retrieved the kidney from somewhere, brought it back to Cardiff, and that was when my shift was supposed to end. And the elderly surgeon who was on call that day said, okay, Elvis, let's go. You do this one. So it was like choosing between going home at the end of your shift or getting to do your first transplant. So I jumped into the occasion, and yeah, he guided me from beginning to the end, but it was very emotional. Yeah, really emotional. Had to grip on the instruments as much as possible. Yeah.
Amazing. And onto your surgeries, Chief was asking, which you answered, about whether repeat transplant is allowable and what determines it or not. And you were mentioning about what's your record so far in terms of the transplants?
Yes, so we did one patient, his fourth kidney transplant. Yeah, so first kidney transplant, if it fails, it doesn't mean the end of the game. You, as I showed earlier on the slide, you use that space above the groin, either right or left. So if you start on the right and you need to do another one, you go on the left. Then if you need to go another one, you go back on the right. If there's space, kidneys tend to shrink a bit in size when they fail. Or if it's still occupying a lot of space, we can remove it and put another one. Then if that fails again, you go back to that other side. Then at times when we've exhausted everything, we make a midline incision instead. We open the abdomen and, implant the kidney directly to the aorta and the vena cava. So you can even do 5. And some mad surgeons can even do more than that.
Excellent. Yes, many questions here. I think I'd like to go to Iya. Iya, what you do is just amazing. Kudos to you. You're courageous. I think some of it has been answered, but by you, Elvis. But can donors be from across the continent? And you've answered that. Can you just explain why? And then I'll go back to Iya's question in a minute. Just explain why if donors can be from across the continent.
Yes, there's some patients who are difficult to match, not because of ethnicity, but because they've got antibodies, and antibodies against human tissue, just to put it in simple terms. And these antibodies are acquired through things like pregnancy, previous blood transfusion, and previous transplant. Some people, they get to a point where out of 1,000 donors, they've got just one person who can donate to them, or out of all the possible donors in the last 12 months in the UK, no one was compatible with them. So they go on some sort of special list, and if by any chance somewhere in Europe we find a match, they can be used in such a patient. Or if on the other hand, there's an organ in Switzerland, for example, which they cannot make use of it, they offer it to the UK.
Okay. All right. And the question for Iya was, Iya, you're such an inspiration. What would you say is the one thing that has come of this that makes you a better person than you would otherwise have been? What good has come of this for you? I guess very deep and personal question there.
It actually is. I would have to say it humbles you. It really, really humbles you having to deal with this, because it's literally not knowing if you're going to wake up tomorrow or if you're going to be fine now and the next minute you're feeling really sick. And that's something that I think my loved ones have had to deal with. It's like sometimes you're laughing or you're posting on social media, just yesterday dancing and like I usually do. And the next minute, if I'm saying that, excuse me, the next minute, if I'm saying that I'm not feeling well, it's almost as if, you're lying, so this really just humbles me a lot. And also, I think my situation opened my eyes to be a little bit more of a humanitarian. And that's how, my foundation was started, being able to help others, seeing how vulnerable I was, and then putting myself about people like in Cameroon and Africa, where their own resources are very limited. It's opened my heart to be there for other people. Yeah. And also just cautioning through, again, our platform, our foundation's platform, spreading awareness, because, I believe truly that this can be prevented through lifestyle modifications, and even the delayed disease progression, can maybe protects you from even dialysis or end stage if you can manage your diabetes, hypertension, and all that. So yeah, I think to answer the question directly, it's humbled me a lot. I can't do shakara, because if I want to do shakara now too much, I don't know if the next minute I will be praying to God to keep me, so, and also make me more of a humanitarian, to be more empathetic against other people's pain. Yeah.
Perfect. Thank you so much. And one for you, Rosemary. Just, you mentioned your foundation at the beginning, and obviously, can you just tell me what the situation is in Cameroon? I know you work with a lot of children that have kidney failure and things. Can you tell me, and you mentioned about obviously doing some projects where you were helping with them to have fistulas and things. Can you just tell us briefly about the situation in Cameroon?
The one good news I have is that, in Cameroon, they used to pay like a $5, is it 5,000 francs co-pay for every dialysis session, because it's heavily subsidized. I mean, it has moved from like 100 and something thousand in the good old days to 75,000, and then it came down to 5,000. And we've been putting a lot of pressure, because so many of these patients they cannot even afford it, even though they have to pay just 10,000 a month. If you look at the fact that the GDP for the whole nation is low, 40,000 is so unaffordable for the average family. So last year, I think the head of the center in Boya sent me a message, because I have about 4 patients there, and I usually just send money directly through the center, and then they go for their dialysis, just to avoid them mismanaging the money. He said they've actually waived that 5,000 francs CFA for all patients, so they don't really have to pay the 5,000, which is very good. But again, we still have the monster of blood donation, which so many patients need. They need blood transfusion when they have blood shortages, which is very common. And Ipogen is a substitute which is not readily available, and it's very expensive. So we continue to also run other programs like blood donation. The kidney awareness month is coming in March. And of course, we are not only advocating for prevention, but we're also sponsoring to help, people to go out there and donate blood, everything. And you'll be very, very surprised that I was so shocked that people sell blood, so somebody really needs blood, they're dying, and there's a seller who wants to donate, but you have to pay them something and then go to the hospital. And that is a transaction that has been taking place across the nation. I've seen it with my own eyes when we took these doctors from Germany. I think there was Dr. Ngassa, Emmanuel, and others. And we went for fistula surgery with some of their colleagues, I forgot his name, but there were like 5 of them. And this patient needed blood. They actually had to make sure that there was someone to come and donate the blood. And when they found someone, that person needed compensation. So how do we move people from wanting compensation for blood you know, so we keep doing other programs, like when we have we're doing the kidney awareness, we also do the blood donation awareness, but we try to give them something else. Like we'll give them some fruits, some vegetables, and then we give them free t-shirts and try to encourage them that they shouldn't be charging people for blood. But most of the hospitals have shortages, like nationwide. So it's something that requires, and I'm glad CamDocUK is really, really active. So all these things are very important that we partner and see how we can really bring hope to all these patients who are really suffering and cannot afford some of these things, even their medications. There are times that even if they don't pay the dialysis, they still have issues paying for their medication. So it's very, very difficult for me to come in a week without seeing messages coming from kidney patients and asking for one help or the other. It's a constant problem. And that's why we continue to solicit for funds from well-wishers. Even if they cannot give, they can at least support in many other ways, even if it's sharing the information with someone who can assist.
Okay, thank you so much, Rosemary. I mean, I know that we have really overrun, but it's just because of how passionate all of our speakers had, where we had 4 of you today, so that was really, really helpful. I cannot end without asking Dr. Ngassa to comment on the state of kidney transplantation in Cameroon. Has there been one done, and what does it look like? You know, we are CamDocUK, so what is the situation in Cameroon, Dr. Ngassa? Any ideas?
Yes, that's a very good question. I mean, we are all very passionate to take our expertise back home and do something great if given the chance. I hope there's some strong Cameroonian politician watching this webinar. I hope our message gets through. These are things we would like to go back home and give our contribution. We just need facilitation from the authorities. So regarding transplantation in Cameroon, the first kidney transplant was done in 2022. Really strange enough, a great country in terms of intellectuals, you know. It came very late. And moreover, was done by a team from Switzerland. They came to Cameroon and worked with some local doctors, and they set up a live donor transplant service. So they've so far done like 6, and the patients were all doing well. They came with all the instruments needed. So I take this as an opportunity to make an appeal to my country that we want to help. We don't want those unnecessary, selfish obstacles when it comes to, you know, doing these things. We will be more than happy and proud to bring back our expertise if the situation is conducive. Thank you.
And thank you so much. And I mean, and that's what we at CamDocUK are about. You know, we have lots of colleagues with expertise, and we would obviously like to help. So, right. So it's been a long day, a long evening, but it's been so insightful. I really want to thank all our panelists for sharing their personal experiences. It was so moving at times. Dr. Ngassa for his professional experience and expertise on the matter. I mean, I cannot go without thanking the people behind the scenes, Dr. Mafo, who has been helping me so far. Normally I'm typing lots in the back, and I haven't had to type much today. Thank you so much, Dr. Mafo. Turn on your camera if you can. Of course, there will be no webinar without Dr. Van Tangwa. He's actually working today. I don't know if he's going to turn on his camera in a bit so we can see him. He's our education secretary. And there he is. There he is. Thank you, Dr. Ngwa, for showing us your handsome face. And of course, last but not least, Dr. Anambene, who is the brains behind getting the webinar up and running and getting everything done. I want to say thank you so much. Look out for our next webinar coming soon. That will be on breast cancer, which is also another very topical topic. That's what we like to do here at CamDoc. Thank you for everyone that turned up, all our attendees. Anna is going to tell me off because I forgot to tell you people about the survey, but I can see that people were already filling that out. So on behalf of everyone here at CamDocUK, and thank you again to the panelists. Thank you everyone for turning up. And you know, what's the message to take home? Please, 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 you know, we need more donors. We know you're doing it. We need more donors. You know, I'm sure all of us has a member of our family that has a kidney issue. You know, so we should think about whether we want to become living donors. We should also, for those of us here in the UK, consider being an organ donor. And you know, really, it's really important. You know, being on dialysis is not something that we want our sisters, our brothers, people that look like us. We don't want us to be stuck on that. So we're able to help. You can survive with one kidney. There's no problem. You're going to be absolutely checked. Any information, any things that you need, there are very helpful speakers here. We're going to put all their websites on there. The Gold Foundation, Atanga Foundation, Iya Foundation. You know, there's lots of us trying to do lots of good work. So on that note, I want to thank you all again and wish you a good night. Thank you and goodbye.